Good evening and a warm welcome to all the delegates who joined us today to listen to an interesting webinar on interlinking genomics and clinical management of CLL. To talk on these sessions, we have eminent speakers, Dr. Rashmi Shamanna, Associate Professor, Department of Hematopathology and Genomic Pathology at MD Anderson Cancer Center. Our second speaker, we have Dr. Nitin Jain, Associate Professor in Department of Leukemia at MD Anderson Cancer Center. To moderate the sessions, we have two distinguished moderators, Dr. Santosh, Associate Professor, Medical Oncology, Chief Bone Marrow Transplant at Ramaya College and Hospitals, Bangalore. And we also have Dr. Vishwanath, Consultant Medical Oncologist, Apollo Hospitals, Bangalore. Without further ado, I invite Dr. Santosh to start the proceedings of the webinar. Here are a couple of instructions for the attendees. Please ensure the internet connectivity is good to have a seamless experience. By default, all the attendees will be on mute and listen only mode. You can use the Q&A section or the chat box to type in your questions. Over to you, Dr. Santosh.
Thank you, Jason. Welcome one and all for this webinar on CLL. This is first of its kind of webinar being conducted by our new startup called CPOEM. I'll just spend a couple of minutes introducing CPOEM. This is an educational tech company started last year by us with a vision of high quality education and collaborative research. Agenda on our plate include innovative educational sessions and workshops, didactic case-based discussions, pathology, genomic, and radiology sessions, collaborative research projects, virtual multidisciplinary tumor boards, and collaboration with leading centers all over the world. I'm privileged to have Dr. Rashmi Kanagal Shamanna presenting for this first meeting of ours. Dr. Rashmi is an associate professor in hematopathology at MD Anderson Cancer Center, Houston, Texas. She is also the director of microarray facility and Department of Molecular Diagnostic Laboratory at MD Anderson Cancer Center. She graduated from St. John's Medical College at Bengaluru, and she did her residency and fellowships in hematopathology and molecular genetics from many premier cancer centers in the United States, including MD Anderson Cancer Center. Her research interests include new drug development for patients with leukemia, especially CLL and ALL. She is also the editorial member for Cancer Genetics Journal and an associated editor for Cancer Medicine Journals. She is accomplished writer with more than 100 peer-reviewed publications. Diving right into the topic, whenever we suspect a CLL diagnosis in our patients in India, we generally run an initial flow cytometry followed by conventional cytogenetics along with FISH with probes for deletion 13q, deletion 11q, deletion 6q, deletion 17p, and trisomy 12. Many labs also run a translocation 11-14 to rule out mantle cell lymphoma, which is a close differential. The molecular panels generally include IGHV mutations and TP53 mutations. In a private lab in our country, the whole workup costs about 45,000 rupees, which is probably equal to $550 US. In the CLL space, we are seeing more and more of new terminologies being used, like Notch1 mutations, BARC3 disruptions, SF3B1 disruptions, or MYD88 mutations. These mutations or disruptions were more used more in other diseases like other hematological malignancies. These are new terminologies in the CLL space. To hear more about this, I invite Dr. Rashmi Kanagal. Over to you, Dr. Rashmi.
Thank you for inviting me. I will start sharing my screen now. And thank you for the kind introduction.
Dr. Rashmi, we are not able to see you.
Oh. Sure. Are you able to see me now? It says
Yes.
the video is on. Okay. Can you see the slides?
Yes.
Okay, perfect. So thank you so much for inviting me to present this session. And I truly believe it's an honor to be invited here. And it's a privilege to talk about the workup of CLL that we do in the United States, specifically as it pertains to how we work it up in MD Anderson. So before going into the genomics, I always believe the conventional assessment based on morphology and immunophenotypic studies, these are extremely essential to workup of any hematologic malignancy, including CLL. There are specific aspects that we can capture from morphology that are not available from genomics. For instance, in terms of CLL, for example, you see the slides here to the right. These are typical small intermediate sized lymphoid cells with the typical nuclear irregular condensation, what we call as the soccer ball appearance. That would be a typical CLL, but on occasions we can see CLL, what we believe would be CLL clinically may be actually undergoing a large cell transformation or a pro-lymphocytic transformation, as we see on the two cells to the right panel here with prominent nucleolus. And similarly, when there is large transformation, we can capture from the bone marrow biopsies or lymph node biopsies, and these certainly are not apparent from genomics. The typical CLL involves either in a nodular, interstitial, or a diffuse pattern, as shown in the biopsy sections below. In addition to morphology, we perform certain immunohistochemical assays to confirm the diagnosis. One is, of course, to rule out mantle cell lymphoma, which is a very close differential in a CD5 positive neoplasm. We do the cyclin D1 immunostain, which is supposed to be negative in CLL. And at the same time, now we have the new positive marker for CLL, which is the LEF1. You can see the upper panel here, which CLL highlighting pretty much all 100% of cells are positive. So this is a nuclear mediator of the Wnt beta-catenin signaling pathway. It is normally expressed in T cells, but not in mature B cells. And it is only CLL and a subset of diffuse large B cell lymphoma that are positive for LEF1, and mantle cells, marginal zone, and any other neoplasm is, all of them are negative. The other aspect we need to remember in cyclin D1 is that it can highlight some cells within the proliferation centers. So proliferation centers are pretty typical for CLL, and sometimes the cyclin D1 positive, cyclin D1 can be expressed in those cells, as we see on the right panel here. And it's important that this not be overcalled as mantle cells. So when we perform FISH on these cases that are positive for cyclin D1 by immunohistochemistry, they are negative for cyclin D1 rearrangement, confirming the CLL. Okay, are you able to see the slide move? I am not.
No, the slides are not moving.
And your video is also frozen, Rashmi.
Oh.
I guess something stuck there. So I'm not sure if you need to unshare and then reshare again, or maybe.
Let me try that.
Dr. Rashmi, you want me to share the screen? I can do that.
That would be easier, I think.
Let me do that, ma'am. Just help me while moving the slide.
Sure. I am not able to come out of this full screen, so just give me 1 minute.
Rashmi?
Yes, are you able to hear me?
Yes, ma'am, we are able to hear you. Is my screen visible, ma'am?
No, I cannot see.
Rashmi, you probably need to unshare your screen, maybe, right? Before.
Yeah, I'm not able to exit out actually.
Dr. Rashmi, shall we start with Dr. Nitin's talk and then maybe your talk in the later on if it is difficult?
Yeah, that may be better.
Santosh, should I start then? Or should we wait for Dr. Rashmi to? Santosh, should I start?
You can share your screen till Dr. Rashmi sorts her internet issue. Dr. Vishwanath?
Yeah.
Why don't you share your slides?
Okay. Do you want me to? Okay.
Dr. Nitin, are you okay to talk next till Dr. Rashmi sorts out the problem?
Sure, yeah. Please.
One second.
Yeah, I just joined by phone. It may be easier.
Okay. So you can continue, Dr. Rashmi.
Okay. Can you share instead of?
Yes, ma'am. Is it visible now?
Yes. So, next slide, please. The other important aspect we can capture from morphology is the size of the proliferation centers. Normally, CLLs involving the bone marrow are not supposed to demonstrate large proliferation centers that go beyond a single hyper view within the microscope. But on occasions, we do see CLL involvement with confluence of areas of proliferation centers. Now, what does that mean? These type of CLL are more likely to have TP53 mutations and other high risk factors. And hence, I think this is an important piece of information that we need to communicate to the oncologists or even maybe to trigger the mutation analysis. Next slide. Then, of course, after the morphology, we have the flow cytometry. At MD Anderson, we have a 10-color baseline panel that we perform in order to differentiate from other entities. We know the typical immunophenotype of CLL, that is CD5 positive, 23 positive. We also do the CD200, which is supposed to be positive in CLL, and its closed differential mantle cell lymphoma being negative. In addition, the intensity of expression of CD20, 22, CD79B, FMC7, and the surface immunoglobulins are dim in CLL as opposed to mantle cell lymphoma and CD5 positive marginal zone lymphomas that express moderate to bright expression. In a very small subset of cases, of course, the what we call atypical CLL, the intensity of expression can be pretty dim. And it's important in those cases to perform additional stains that I mentioned, like LEF1 and FISH to rule out other diseases. Next slide, please. Then we have the basic chromosomal abnormalities. We have the, I guess pretty much across the board, everyone now performs the routine clinical FISH for the 4 classic abnormalities, the deletion 13q, 11q, 17p, and trisomy 12. And several studies have established the prognostic impact of these abnormalities that made it possible to incorporate this as a routine workup in every disease. In addition, again, since mantle cell lymphoma is a closed differential, we might have to do its translocation 1114 or CCND1 translocation by FISH. And it's also important to identify in less than 5% of CLL cases can have IGH fusions. And we do an IGH break apart to identify that. because it has prognostic value in CLL. Next slide. Unlike fish, the traditionally conventional karyotype was not that helpful because we didn't have effective mitogens to stimulate proliferation. But now we are able to grow the karyotype very successfully, and karyotype is able to pick up at 30% more abnormalities than what's done by fish. In addition, most of these additional abnormalities are translocations, and the breakpoints involving the same deleted regions of the four regions that I mentioned that we evaluate by fish. Now, the IGH fusions that I mentioned can also be picked up by conventional karyotype if we don't target it by fish. The most frequent being fusion to BCL2, that is often seen in the mutated CLL, and with BCL3 and BCL1A, which is seen in the unmutated CLL cases. Next slide. The additional information that we can obtain by conventional karyotype that will be missed by fish is the presence of complex karyotype. Can be seen in about 20% of CLL cases and in a small proportion of monoclonal B lymphocytosis as well. So it's not nearly, it doesn't mean actually that it's an advanced disease. It can occur way early on. It's just a reflection of disease biology. The definition is the same as in other neoplasms, 3 or more numerical or structural abnormalities. And the presence of complex karyotype predicts for disease progression and worse outcome. And this prognostic impact is independent of the presence of TP53 aberration. In addition, the degree of complexity is also important. For example, more than three abnormality CLL does much better than 4 or 5 abnormality CLL. Next slide. The other technology that we frequently perform that can capture in a more objective way the degree of genomic complexity is the chromosomal microarray testing. So using the chromosomal microarray tests, several studies have reported additional prognostic copy number aberrations in regions 2q, deletion 3p, deletion 6q, or even deletion 15q involving these genes that can influence the outcome. And the copy neutral loss of heterozygosity, pretty much chromosomal microarray is the only technique that can pick up the CNLOH. Not even NGS at this time can pick up these abnormalities. And these are present in about 5% of cases and often involve 11q, 13q, and 17p. And the presence of copy neutral loss of heterozygosity kind of hints that there might be biallelic inactivating mutations of the evaluated region, often the TP53. Next slide. So this was a very recent paper that was published this year. They actually quantified the genomic complexity based on chromosomal microarray into 3 categories. So less than 2, 2 to 5, and more than 2. And they showed that these are in defined new prognostic subsets. Next slide. So now moving on to the immunogenetic subtypes, everyone is now aware that there are 2 broad CLL subtypes, the unmutated CLL based on the IGHV status and the mutated CLL. So the mutated CLL has less than 98% homology between the germline IGHV sequence, and it usually has a less aggressive course, and the cell of origin being the post-germinal center that's already been exposed to the antigens. On the other hand, the unmutated CLL, it has less than 98% homology with the IGHV sequence, the origin being from the naive B cells, and these are supposed to be more aggressive. And now it's very well established that the mutated and unmutated CLLs have distinct prognosis using conventional therapies, although use of newer agents may not show such a dramatic prognostic difference. Next slide. So how do we evaluate for this IGHV or the somatic hypermutations status? So traditionally, we used to use Sanger sequencing, where we evaluated one sequence and compared it to germline. And depending on the quality of the sample, the sequence would not be that clean for us to establish or evaluate this quantitatively. Now we use more sophisticated NGS-based technologies, and we adopt the ERIC guidelines that has recommended that still recommends the 2% cutoff. And because we use the DNA for as an input, we are able to evaluate the productive and non-productive products and make the assessment. And we only do this one time because repeat assessment, it's the biology of the disease and will not change with treatment or time. Now, here are the 3 examples where we see the prominent clone popping up, and we are able to identify the specific IG, the IG and the JH sequence as well. And that will be helpful for, if you can move to the next slide, to evaluate the stereotype B cell receptor status. So many of the CLLs, despite having different clones, they all have near identical CDR3 or complementary determining region. And there are about 19 well-defined stereotypic subsets within the CLL and about 20 within each of these. And again, these have prognostic value, so it's important to determine the stereotypic B cell status. For instance, the V3-321, irrespective of the status of the mutation, is supposed to behave more aggressive. Next slide. So in addition to the IGHV status, we use NGS to do our molecular profiling of pretty much every new CLL case that comes through our institution. Now, traditionally using, I believe whole exome sequencing was done on 4 CLL cases and they identified recurrent drivers, but now the literature has evaluated nearly thousands of cases and we now know the spectrum of the mutations. Now, fortunately or unfortunately, this, as we can see, there are some recurrent drivers that are seen at the top, but then there is this whole tail of mutations that happen at much, much lower frequencies. Now, the highest frequency is, the highest gene mutation frequency is only 3%. That would be the TP53 or SF3B1, and that is only seen in about 5% of CLL cases. Now, unlike the myeloid diseases, there are many types of CLLs where we cannot even identify a genomic driver. So when we, as a molecular pathologist or a hematopathologist, when we are designing panels, it's important for us to be aware of this whole spectrum of genes, this nearly 100 genes that are involved in CLL, and to incorporate them all in the panel. In addition, the complexity of CLL is compounded by the fact that the genomic profile changes with time, even without therapy. So the profile is different when you at the time of diagnosis or sometime later. So it's kind of important to sequentially perform this whenever the treatment is planned. So what are the things to keep in mind when designing a panel or when you're selecting a lab to send the panel? So the panel that should be, the panel should be inclusive, right? It should incorporate all of the genes that are involved in CLL biology. And in addition, it should incorporate genes that are close differentials to CLL. For example, MYD88 or CXCR4, or even CCND3, the mutations can be seen in mantle cell. So on occasions, when it's a very challenging case, we are able to identify some of these biomarkers and then go back and rework it. Now this, we also need to acknowledge that there are some CLLs that can show MYD88 mutations as well, but it's important to bring this to our attention and go back and make sure the diagnosis is all right. And in addition, it should incorporate the prognostic genes that TP53 included, as well as some the other genes that can show resistant mutations with these novel therapy like BTK or PLC gamma 2, etc. Now, when we are actually evaluating the panels, it's not just enough if the genes are included, but the amplicons of the panel should incorporate those hotspot regions. For example, for the BTK, the C481 codon, that's the mutation, that's the hotspot mutation for resistance. We have to make sure that the amplicon covers that region, and in sufficient coverage too. It should be at least 1000x or over to determine the low level mutations. Next slide. And depending on, and the third important aspect is the technology, right? There are amplicon-based NGS panels, there are capture-based panels, two different broad types. Now we know the amplicon-based panels is mostly PCR-based, and it can result in false amplifications of certain mutations. So we cannot go down to say less than 5% or 2% cutoff, and it could be false artifactual mutations that can pop up. On the other hand, the capture-based with molecular barcoding is very accurate. So we can go down to the VAF of 1 to 2%. And in CLL, we know that's super important because the subclonal mutations are just as important, just as prognostic as clonal mutations. And it's important for us to pick up certain resistant mutations early so that the therapy can be modified appropriately. And specifically for CLL, sometimes because of Richter's transformation and involvement as SLL, we need to have the panel that is compatible with formalin-fixed paraffin-embedded tissue and not just the bone marrow or peripheral blood. For CLL per se, the depth of coverage should be at least 1000x, just so we have the lower limit of detection of at least 2%. So that's important to identify, as I mentioned, the subclonal mutations, especially for genes such as TP53, the BTK and PLC gamma 2, as well as the BCL2 mutations that can be seen with venetoclax therapy. Next slide. So just to highlight some of the points, I'm going to illustrate it using, say, two genes, so TP53 mutations. We know that, so at baseline, it could be at very low level, or it could be not detectable. So if we use NGS technology, maybe the disease at baseline could have 1 to 2% VAF, TP53 mutation at 1 to 2% VAF. But with chemotherapy, these clones get selected out and they progress and expand later. So we need to make sure that even mutations at 1 to 2% VAF have been called and communicated to the oncologist. And for that reason, even now, the recommendation, the standard recommendations is to do Sanger sequencing for TP53, even though we pretty much know the sensitivity of Sanger is 10 to 20% VAF. So anything below that, we will miss it. So obviously at baseline, if we use Sanger sequencing, the TP53 mutations will not be picked up. So pretty much NGS is the only technology that allows this detection. And the Notch1 mutation, for example, is seen in 15% of CLL. The most frequent is the frameshift or nonsense mutations involving exon 34. The 2 base pair deletion is seen in about 80% of cases, but in about 20%, we see the non-coding mutation that's located in the 3' UTR region. So when we select the lab or the panel, or when we design the panel, we have to make sure that the 3' UTR is incorporated in the Notch1 gene. And this is important not just for prognosis, but also the Notch1 mutated CLLs can express lower levels of CD20 that makes them makes the use of rituximab not so useful. Next slide. So again, as I mentioned a few minutes before, the resistance to novel agents, the Ibrutinib and the venetoclax are being increasingly used nowadays. So with use of BTK inhibitors, the mutations in BTK and PLC gamma 2 induce resistance and lead to disease progression or even transformation to Richter's. And the same with venetoclax, there are several BCL2 mutations that have been identified. Now, these are not present prior to therapy or maybe present at very low frequencies that we cannot identify. The importance is once the patient is started on therapy, when we sequentially perform it, these mutations pop up much earlier than florid clinical progression. So these can be used as markers to identify potential progression, and it can lead to early modification of therapy. So it's important that sequential NGS is just as important as baseline profiling. And in addition to mutations, there are several other alterations such as deletion 8p and the ITP-KB mutations that have been implicated but not performed for routine use. Next slide, please. So this is one of the studies that was performed at MD Anderson, where we confirmed the presence of BTK and PSC gamma2 mutations by profiling the baseline and sample set progression. But the highlight of this paper is that it's actually in more than 50% of the cases, the other mutations were implicated. So SF3B1, TP53, etc. So it's not just important to sequence for BTK or PLC gamma using a single gene assays, but it's important to profile, do the whole panel, NGS panel, to make sure that we are not missing the clonal evolution. Next slide. So just to summarize what I've spoken so far, so CLL is the landscape of mutations is pretty complex. So the interpretation or translation of this genomic understanding to the clinical is kind of complicated by three separate things, right? One is the genomic complexity, where it's not one patient has one mutation. It's the combination of multiple mutations. So if TP53 with SF3B1 and ATM or TP53 alone, all of these behave differently. And the second thing is the subclonal composition, for which pretty much targeted deep sequence NGS is needed to pick up low frequency mutations. Now, the presence of subclonal driver mutations has an independent predictive value for the disease progression. So it's not just the number of all clonal mutations, but it's the total number of subclonal mutations also is predictive. And the third is, of course, clonal evolution, sequencing at baseline, and then sequencing at later time points where additional mutations are acquired. Next. So there have been quite a bit of efforts that have been undertaken in order to translate this genomic profile into prognostic models to better assess the risk of the disease in this genomic era. So the first, of course, the IGHV mutation status in the fish remains the same. Then Rossi and other authors tried to incorporate the mutation as well as cytogenetics into one risk model. And that's what's shown here. They incorporated deletion 13, trisomy 12, and no recurrent genetic lesions, Notch1 and or SF3B1 mutations, and or deletion 11q. And then fourth category, the TP53 mutations with BRCA3 alterations. And these were clearly prognostic. And if you, the next slide. And later on, this is more recent, and I guess there is more interest in this prognostic model, the CLL International Prognostic Index, where they incorporate the clinical, the age, the stage, as well, and the beta-2 microglobulin level, as well as two important mutation results. So that is the deletion 17p and or TP53 mutation. So the p53 aberration and the IGHV mutation status. And they also, they found 4 prognostic subgroups in that were validated in 4 different cohorts. The most important thing here is the TP53 aberration had the highest impact on prognosis, the score of 4, followed by the IGHV mutation status. So it's really important to assess these molecular biomarkers in order to evaluate the prognosis. Next. So before Dr. Jain goes into details about the therapy, I just wanted to briefly present with this slide how this genomics has modified the therapy, right? So the chemoimmunotherapy, that's the cornerstone of a CLL treatment, that is still effective to treat the mutated CLL and the CLL with wild type TP53. So the chemoimmunotherapy is also effective in unmutated CLL and in CLL with TP53 aberrations. The chemoimmunotherapy is not effective in treating unmutated CLL and those with TP53 aberrations, and the novel agents such as Ibrutinib and other drugs are now increasingly used here. Now, Ibrutinib can also be used in mutated CLL if the patient prefers, or if the chemotherapy is pretty toxic, in which case Ibrutinib can be used here as well. When we use the Ibrutinib in unmutated CLL or the p53 mutated, or altered CLL, it's important to perform sequential NGS to identify these resistance mutations, not just in BTK and PLC gamma 2, but also in BCL2 and other genes, so we can tailor the therapy. It's kind of highlighting the precision genomics that is now kind of becoming universal. And the final slide. So just to summarize my talk here, it is the clinical decisions are now increasingly guided by molecular testing. The two most important things being the TP53 aberration status and the IGHV mutation status. As hematopathologists or molecular pathologists, it's our role to establish the most appropriate techniques in order to determine the status of these alterations and communicate it to oncologists. Now, as we're aware, the TP53 aberrations are extremely prognostic, even at a small subclonal level. So pretty much NGS is the only technology that facilitates its detection. And there has to be efforts, global efforts, that should be geared towards standardization of the NGS technologies and the analytical pipelines in order to convey this information. And the role of conventional Sanger sequencing is questionable in the genomic era. Next slide. Thank you. Any questions?
Thank you, Dr. Rashmi, for that wonderful presentation. We have few questions which we want to discuss in the next 5 minutes or so. So coming to the first question, why does this is basically for the uninitiated. Most of the patients who have started on BTK inhibitors develop lymphocytosis. Is there a pathophysiological basis for this?
Okay, can you repeat the question? I couldn't hear.
Pathophysiological basis or a molecular basis for lymphocytosis that occurs in patients with who are started on BTK inhibitors.
The molecular pathogenesis for that lymphocytic, like, you know, the compartmentalization where the lymphocytes move into the peripheral blood, it's not clear. It's kind of uncertain why the drug causes that. But I guess from our perspective, when there is increasing lymphocytosis, even with BTK, it's important that we should not we should not see that as a sign of progression or resistance. And in the absence of BTK mutations or other mutations that are reflecting that, it's kind of reassures you, like when we perform, there are no mutations, but it might be just that it's a treatment effect or a transient treatment effect.
Thank you. So many times, even in patients with low risk CLL, we get a P53 positive. Most of the labs give a P53 positive that may be few percentage points, say 5%. When do you take this P53 gene mutation positive, at what cutoff? Is there a percentage that we take for positivity?
Yes. So when we are validating the assays, the NGS assays, we do the dilution studies, and we try to. So basically, in NGS, the higher the coverage, the lower you can go. So when we are validating the assay, we have determined at least 1000x coverage. So if you get 1000 sequences, we are able to identify at least 2% mutations at 2% BAF, and these are true mutations and not artifacts. So if we want to go much lower, you just have to increase the coverage. This is during the validation when we are developing the panel. For in our institution, the validated cutoff is 1% for the TP53 single gene assay and 2% for the NGS assay. So we can, anything below 1%, we would not call that out.
Is it 1% or 2%? Is it clinically significant, or do we make clinical decisions based on this 2% positivity?
Yes. I believe there's a paper in Hematologica that has shown that anything over 2%, even at 2% or over, is clinically prognostic.
We know that IGHV gene mutate unmutated CLL patients are resistant to chemoimmunotherapy. Again, this is something that we don't understand. Why do these patients don't respond to the treatment like FCR?
I am not very certain, but what I mean, we know that the unmutated CLLs tend to have the TP53 mutations more frequently. I believe the Notch1 mutations are more frequent as well. That may be responsible for the resistance. Like I mentioned, the TP53 mutations, we know that these are resistant to chemotherapy, so they kind of escape the chemotherapy, and those are the only cells remaining. P53 mutated cells are the only remaining after chemotherapy, while every other cell is dead. And so that gives them an advantage to expand during that phase, during the recovery phase, and that can lead to progression. But for the TP53 unmutated cases, I would imagine might be the same case with the other genes, but I'm not certain about that.
So how important is it to do both the cytogenetics for deletion 17p and also P53 in the same patient? If you get a cytogenetic that is deletion 17p positive, do you have to still run a P53 by either Sanger sequencing or NGS, or is it enough to have a deletion 17b set by cytogenetics?
At this time in CLL, I think the Haferlack paper has shown that most of the time it's biallelic. So either there are two TP53 mutations or deletion 17p with TP53. So if one is present, the other is likely to be present. So technically, if I didn't have the money, if the 17p is deleted, I wouldn't do it.
Okay.
Just because I think 90% of cases will most likely have it. But I don't think there is a study that's looked at monoallelic versus biallelic, the differences per se. Most of the studies that have evaluated the prognosis have just lumped them together as TP53 aberration. So either deletion 17p or mutation. So technically, if I want to save if I want to be super cost effective, if deletion 17p by FISH is negative, then I would do the mutation. I would chase after that much more thoroughly.
Okay, thank you. Are you using NGS for routine patient care in CLL patients at MD Anderson Cancer Center?
Yes, every patient, every new patient, at least any patient that, I think Dr. Jain will also elaborate on it. Any patient that needs to be started on treatment, or even for basic evaluation, we do NGS using the 100+ panel at MD Anderson.
Okay. And do you advise repeat flow cytometry or cytogenetics NGS at each relapse of these patients of CLL?
Yes, for flow cytometry and cytogenetics, yes, absolutely, at every relapse. At our institution, we in fact perform that even every time the patient gets some marrow, which may not be really necessary if I mean, it may not be, I think, cost effective, but definitely at relapse.
Okay. Thank you so much for that, Dr. Rashmi. It was a wonderful educational session, and we really value your presence today here.
Thank you so much.
I hand it over to Dr. Vishwanath for the next session.
Yeah. Am I audible?
Yes,
Dr. Vishwanath.
Okay. Yeah, thank you so much. That was a wonderful talk, Dr. Rashmi, and thanks for the moderation, Dr. One second. Sorry. Happening. It's got stuck. Yeah. Thank you so much, Dr. Rashmi, and thank you, Santosh. Let's go on to the next part of the meeting. So, so I'll be introducing Dr. Nitin Jain, who is our second speaker. He's an associate professor in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. And he's trained from the All India Institute of Medical Sciences and then further fellowship, residency and fellowship in premier centers in the US. Research interests include new drug development for patients with leukemia, especially chronic lymphocytic leukemia and acute lymphoblastic leukemia. In fact, he's a principal investigator of several clinical trials in CLL, including the Ibrutinib with venetoclax, which was a New England Journal of Medicine publication. And he's also the proud recipient of the Sabin Family Foundation Award in 2018. So, of course, it's a big clinical decision making in treatment naive CLL in India. I just want to give a broad overview before to just set the ball rolling before Dr. Nitin Jain starts his talk. So most clinicians in India use then bendamustine and rituximab in the first line treatment of chronic lymphocytic leukemia. And the decision making is quite complex has become quite complex with the advent of novel drugs and the small molecules. Biosimilars of rituximab and the generics of ibrutinib, lenalidomide have all made treatment of lymphomas and chronic lymphocytic leukemia more affordable in India and more accessible as well. And with the availability of obinutuzumab and the recent entry of acalabrutinib recently, so the options for treatment of CLL have significantly aggrandized, and wide availability of the next generation sequencing and fluorescent in situ hybridization, like Dr. Santosh also mentioned, have also augmented better decision making in chronic lymphocytic leukemia. So, so the various clinical scenarios, and as medical oncologists, we have difficulties in decision making. So broadly in CLL, we can have an unfit patient who can be a standard risk, or an unfit high risk patient who's generally talking about elderly patients. So when you're talking about standard risk, it could be a mutated IGHV gene with a standard cytogenetics of deletions, 13q deletion by fish, and the patient could be elderly. And then you could have an IGHV mutated, but the patient may have P53 mutation positivity, or it could be an elderly patient coming in with unmutated IGHV with 11q deletion. Generally, these patients have known to have bulky disease. So these kind of scenarios are very common in elderly patients. And not only that, talking about fit standard risk and fit high risk patients in the younger patients, it could be again a mutated IGHV gene with a trisomy 12, which is generally having a better prognosis, or it could be a mutated IGHV gene with a 17p deletion by fish. And now with the advent of next generation sequencing, we could have something like a BTK C481S gene, which is found, which could be resistant to BTK inhibitors. So these are the different clinical situations we may find, and I think Dr. Nitin Jain would definitely address these situations. So coming to the cost of drugs in US and India, in fact, I had the pleasure of penning down this article with Dr. Christopher Flowers and Dr. Swaminathan Iyer, where we compared the cost of drugs between and the accessibility of drugs in lymphomas and CLL between India and US. You could see that rituximab, in India, it's around $550. There is also a robust patient assistance program. Mind you, these drugs, whatever mentioned here is without the patient assistance program, and the cost in the US is probably like 8 times higher. Similarly, obinutuzumab, 1,000 milligrams costs around $5,450 without the patient assistance program. And the cost in the US for a 1,000 milligram vial is around $6,200. So we have Ibrutinib, we have the innovative brand, which is around $4,400. And the cost becomes half with the patient assistance program, and it's around 3 times higher in the United States. And we have a generic Ibrutinib. Several generic molecules have come in, and the cost of 1 month's therapy, when you're talking about 420 milligrams for chronic lymphocytic leukemia, it's around $410 in India. And I think the generic molecule is not available in the United States. Talking about acalabrutinib, it's right now it's quite expensive in India, but we have a significant robust patient assistance program. But without that, it's around $9,700, and in the US, it's around $14,260. And venetoclax, unfortunately, at this point in time, is not available in India, but we do have access to drugs coming to import it from UK and various other European countries. And the cost of maybe 100 milligrams of 112 tablets is with all the import customs and all that comes to around $1,400 approximately. And the cost in the US is around $12,000. So with this broad overview, I hand it over to Dr. Nitin Jain, our expert for today, to go ahead with his talk. Thank you so much, Dr. Jain.
All right. Good evening, everyone. Can you hear me?
Yes.
Okay, perfect. All right, so thank you for the nice and kind introduction. So I guess my job today to talk to you about treatment of CLL, obviously with focus of how we are practicing at MD Anderson and in general the concepts in the United States. Certainly you have to, as was discussed with the cost issue in India, you have to kind of tailor your treatment for your patient based on the affordability of the drugs. So these are my financial disclosures. So I think as Dr. Rashmi also kind of alluded in her talk, the therapy of CLL has changed quite remarkably. So in the last 6-7 years now, we have BTK inhibitors, PI3 kinase inhibitors, BCL2 inhibitor, venetoclax, which is the only one so far. We have CD20 antibody obinutuzumab, and all these are approved. So we have 2 BTK inhibitors approved, Ibrutinib and acalabrutinib, and then we have venetoclax approved, which is a BCL2 inhibitor. And very likely, I think in the next year or so, we'll also have zanubrutinib approved for CLL. It's already approved for other lymphoma, for mantle cell, but not for CLL. And there's also a new PI3 kinase inhibitor, umbralisib, which will likely be approved as well. And then there are trials happening with CAR T-cell therapy. Again, these are relapsed refractory patients. But again, those are strategies which hopefully, depending on how the results pan out, may get approved for CLL in the next couple of years. So the field has changed quite dramatically. And if you're talking about the patients with CLL, so I think in the frontline setting, we have moved away from chemoimmunotherapy era, which was use of FCR for young fit patients, or bendamustine rituximab, chlorambucil for older adults, to the targeted therapy era where we're considering FCR really for only a specific group of patients, which is this young fit mutated IGHV patients without any deletion 17p53. So that group constitutes only 10% of the entire patient population. Rest of the patients, I think in the United States, it has become very clear with the data I'm going to share with you that we should be using targeted therapies for the patients. So the role of chemotherapy has really declined substantially because of the new drugs. And this is kind of showing the treatment paradigm for these patients. Again, I think if you look at the treatment naive kind of a chart here, let's see if we can use my pointer. You can see the treatment naive chart here. The FCR therapy is really restricted to this young fit IGH mutated group. Everyone else, the 3 approved strategies in the frontline setting include ibrutinib, acalabrutinib, and also venetoclax in combination with the venetuzumab. And one thing I would say that if you have a patient with deletion 17p or p53 mutation, though venetoclax plus obinutuzumab is approved, there is data, and I'm going to share with you, that these patients may not derive long-term benefit with the 1 year of therapy. So I think for these patients, a BTK inhibitor, either ibrutinib or acalabrutinib, would be the preferred choice. So let's talk about treatment in a bit more detail. So let's first focus on the young fit patients. So these are the patients I would say are FCR eligible. These are patients in their 50s, otherwise fit, and are needing treatment for their CLL. So just to kind of bring something to perspective, the FCR studies initially were done by Dr. Keating here at MD Anderson. And the first report came out now 15 years ago, which was treatment of FCR in the first 300 patients which were treated. And that really established FCR as one of the effective strategies for patients with CLL. And this is before, obviously, the Ibrutinib era, the target therapy era. And then came the CLL-10 study, which was a head-to-head study comparing FCR versus bendamustine rituximab. And again, this study was designed before the Ibrutinib development. And the goal here was to see how these 2 standard chemoimmunotherapy regimens fare against each other. So this was the original report, which was now 5 years ago, where actually it showed that the FCR is superior to bendamustine rituximab for progression-free survival, which was the primary endpoint of the study. So really, if you have a young patient, if your goal is deep remission, prolonged remission, FCR is probably the way to go based on this head-to-head study. And they recently updated this data, a longer follow-up, which again, pretty much the data is consistent that the patients who received FCR did better than patients who received bendamustine rituximab. So certainly, I think this trial established that for the young fit patients, if you have a choice of chemotherapy, or if you want to do chemotherapy, FCR would be the way to go. And then there came this trial called the ECOG E1912 trial, which was a trial where what the investigators did was for these young fit patients, they randomized them head-to-head, ibrutinib rituximab versus FCR. So the goal here was FCR is the standard. Can we replace that with ibrutinib plus rituximab combination? And obviously, ibrutinib is then continued kind of long-term as you would do for any ibrutinib patient. This was the progression-free survival, which the top curve is ibrutinib rituximab. So clearly, ibrutinib is better than FCR for this patient population. So that's pretty good. When you look in the subgroup analysis, what appeared was, and this was a question which was asked in the Q&A session to Dr. Rashmi as well, that the unmutated patients, there was a wide separation of the curve between ibrutinib versus FCR arm. But for the mutated IGHV patients, the curves were overlapping. You can see the p-value is not significant, though it was close to 0.05. So this made two arguments. One is that if you have patients with IGHV unmutated, at least in the United States, we are not using chemotherapy for those patients because you really clearly have a wide separation of the PFS curve for these patients. On the flip side, if you have IGHV mutated patients, I think for these patients, the choice is yours. If you want to do chemoimmunotherapy, I think that's fine. If you want to do ibrutinib rituximab, I think that's fine. So at least in the United States, I would say, most patients are not choosing chemotherapy just because of the risks associated with myelosuppression, MDS, AML. So I think most patients are really going on target therapy. So this is an important trial, and hopefully we'll see an update to this trial to see how these curves are doing now another couple of years down the line. This trial also showed OS benefit actually in favor of ibrutinib rituximab. So again, making a point that that ibrutinib is better. Practically all the deaths in this study occurred in unmutated patients. So again, mutated patients are doing equally well. Unmutated patients, wide separation of the curves. So that was the young fit patients. What about older patients? And that's really where most of the patients come to practice, who are maybe above 65, maybe on the frail side. So you don't want to use chemotherapy for these patients. So here, the ibrutinib was the first one approved. This was originally based on this RESONATE-2 study, which was ibrutinib versus chlorambucil. And here is the 5-year follow-up, which is the most recent update, where at 5-year mark, 70% of patients who received ibrutinib were progression-free, as opposed to practically less than around 10% with chlorambucil. So really, this trial led to the approval of ibrutinib in the frontline setting. And it's a nice number to remember. I tell my patients, if they ask me how long I expect the remission to last, on an average, you can say 70% at 5-year mark. But one of the criticisms of the trial was that it was comparing chlorambucil. At least in the United States, we don't use much of chlorambucil. So, and as you kind of alluded to, that in India, bendamustine rituximab is a favored chemotherapy for the frontline setting, and that has been true for a long time in the US as well. But then came the Alliance trial, which was a trial for older patients where patients were randomized to bendamustine rituximab versus ibrutinib rituximab. And what the investigator showed is that for progression-free survival, both the ibrutinib arms were superior to bendamustine rituximab arm. So there was no OS benefit. However, patients who are getting ibrutinib, they had a better progression-free survival, which was the primary endpoint of the study. So based on this data, I think really a lot of clinicians in the US who are using bendamustine rituximab as their preferred first-line therapy have now moved over to ibrutinib-based therapy. But ibrutinib was the first one in the market, but now we have acalabrutinib and we have zanubrutinib as well. And what you see here, the dots on this kinase map are what kinases these drugs inhibit besides the BTK. And what you see here is that ibrutinib has several off-target effects. Acalabrutinib seems to be a bit more specific for BTK, and then zanubrutinib is kind of in the middle. And that may be why the safety profile of these drugs is different. We see much more side effects with ibrutinib as opposed to the other two BTK inhibitors. So for the acalabrutinib, the trial which led to the approval of acalabrutinib in the frontline setting was this ELEVATE-TN study. So again, kind of the same concept, older patients, they were given acalabrutinib obinutuzumab or acalabrutinib alone or chlorambucil obinutuzumab. So this was the last update of the study, where what the investigators showed is that both the acalabrutinib arms were superior to chlorambucil arm. So really, I mean, acalabrutinib is doing fantastic here. And there appears to be a small improvement of adding obinutuzumab to acalabrutinib, whether that will stay, whether that small difference of 6% PFS at 2-year mark will continue to be maintained with a longer follow-up remains to be seen. But at least, you know, the data looks very nice in favor of acalabrutinib versus chlorambucil. So now, you know, you have these 3 BTK inhibitors. So we didn't talk much about zanubrutinib, but zanubrutinib is another BTK inhibitor. And there are 2 randomized trials happening head-to-head in relapsed CLL, which is ELEVATE-RR trial, acalabrutinib versus ibrutinib, and the Alpine trial, which is zanubrutinib versus ibrutinib. So again, you know, and we already know from the press release, which was issued last month, that acalabrutinib versus ibrutinib, the trial showed non-inferiority for the safety, or for the efficacy between the two, and then acalabrutinib led to statistically significant less atrial fibrillation compared to ibrutinib. So that trial has not been published or reported. Hopefully it will be at ASCO or EHA, we'll see. But that, I think, study will be important to see. And then we have the zanubrutinib trial, which is not yet reported. So again, I mean, I think there's a general thinking based on the clinical trial data that the 2nd generation BTK inhibitors will be safer than ibrutinib. This was a phase 3 trial in Waldenstrom, so not in CLL, but zanubrutinib versus ibrutinib came out in Blood last year. And I just wanted to highlight, if you look at the rates of atrial fibrillation, 15% with ibrutinib versus 2% with zanubrutinib. So this is the first head-to-head trial reported in any indication between the 2 BTK inhibitors, and really clearly favors for safety zanubrutinib. So again, I think we'll have to see how the data will come out with acala and zanu in CLL, but I think evidence suggests that they will likely be safer than ibrutinib. So I showed you the data with ibrutinib, with acalabrutinib. Obviously, if you keep taking these drugs, the progression-free survival looks impressive. But the issue here is that it's an indefinite therapy. Obviously, cost is a big issue in India if you want to continue these drugs for long term. These lead to low CR rate, low MRD negativity rate. So the theory in the thinking in the field is emerging that, as we were doing previously with FCR and BR, we give time-limited therapy for 6 months with chemotherapy, and then you stop, and then you watch these patients, and patients may achieve a long-term remission before they need treatment again. So can we dial back the treatment duration? Because when ibrutinib and acalabrutinib came, the thought was, oh, these drugs we need to give for life, and that's what obviously the trials were designed for. So then came this approaches of time-limited therapy, which can lead to high MRD negative remissions. So one of the first one was, or which led to the approval, was CLL14 study, which is a randomized study for older patients when obinutuzumab versus chlorambucil obinutuzumab. So this drug is given only for 1 year. So venetoclax is for 1 year, obinutuzumab is for 6 months. And when you look at the most recent progression-free survival, and this is for the ASH meeting a few months ago, when obinutuzumab has a PFS of 74% at 4 years compared to chlorambucil obinutuzumab. So certainly it's better than chlorambucil for progression-free survival, it's quite clear. But the thing here to note here is that these patients stopped venetoclax at 1 year mark. So what you're seeing, the remainder of this curve for 3+ years is off therapy. They're just being monitored, these patients. So that's quite remarkable, right? You give 1 year of therapy, and then majority of the patients are just in remission, kind of at least 3+ years down the line. The one thing I did mention to you is that for patients with deletion 17p, if you give this 1 year therapy, and what you see here are these patients who are relapsing. So this curve with venetoclax or obinutuzumab and patients who have deletion 17p or p53 has led to the argument that 1 year of therapy is not appropriate for these patients, and these patients should preferably be treated with a BTK inhibitor, which has a more durable responses seen with this group of patients. So one of the things which comes up for discussion in the clinic all the time is that, at least in the United States, and I think same thing in some sense applies to India, if you look at the target therapies, we have Ibrutinib, we have acalabrutinib, and we have venetoclax plus obinutuzumab. So which is the best option for a particular patient? So here, I'm just comparing the efficacy for the two trials, the RESONATE-2 study, which is the Ibrutinib, and the CLL14 study, which is the ven obinutuzumab. And the most up-to-date data we have is a 4-year PFS of 74% with the ven and 5-year PFS of 70% with Ibrutinib. So quite comparable in terms of the PFS. And if you look at the, whenever you do cross-trial comparison, you have to see what is the age, what are the prognostic markers among the two groups. And actually, they're pretty well matched, except that actually more patients with comorbidities were enrolled in the CLL14, because that's what one of the criteria for enrollment was, comorbidities. So these patients are actually have more comorbidities in the venetoclax arm. And then you see here is that 1 year of therapy is giving you equal PFS than continuous daily therapy with Ibrutinib. So to me, that is kind of in favor of time-limited approach, that you're able to achieve durable remissions as equal, almost, than daily BTK inhibitor. And one of the reasons it's able to do that is that when you give ven obinutuzumab, patients achieve MRD negative remissions in a high proportion of the patients. As you can see here, 75% of the patients in the blood were MRD negative with after getting ven obinutuzumab. If you were to ask what is the number with Ibrutinib or acalabrutinib alone, it's practically 0. You don't get MRD negative remissions with the single agent BTK inhibitors. And the one other important point I would say is that, when you look at the data, there is all this discussion of CR versus PR, clinical trial data when you look at, but one of the most important factor is really the MRD. So if you look at, this is the data from ASH in a poster session. If you're MRD negative, and whether you're a CR or a PR, after getting ven obinutuzumab, your outcomes are equally good. So really doesn't matter if you have a small lymph node left, which may be called a PR from a clinical trial standpoint. But if you're MRD negative in the blood, you're going to do well. So in the next maybe 5 minutes or so, I just want to kind of first recap of what we kind of talked about. So the 3 treatment approaches in the frontline setting, target therapies, are Ibrutinib, acalabrutinib, and ven obinutuzumab. So there are pros and cons of these approaches. With Ibrutinib, we have the longest follow-up for these patients. Certainly, it's an indefinite therapy, low rates of remission, and then we have to deal with atrial fibrillation and bleeding. Certainly in the Indian context, because of this generic cheap version available, I think it's more affordable for the patients. For acalabrutinib, it has reduced off-target effects. Otherwise, some of the side effects which you see with Ibrutinib are still here, but they're at a lower frequency. And this drug in general is better tolerated than Ibrutinib. And then when obinutuzumab, the big advantage is a 1-year therapy. So everyone is happy, patients are happy, they don't have to take drug for a long time, cost consideration leads to high rates of MRD negativity. The only downside is somewhat shorter follow-up. We only have 4-year data right now. Tumor lysis monitoring, you have to monitor these patients for TLS, which is more like a logistic issue. You have to arrange for labs and things like that. Obinutuzumab is given IV, so you have to, get the patient in the IV unit for infusion. Neutropenia occurs in 50% of the patients, so that's something you have to remember. And then we talked about this, that deletion 17p53 may not benefit from this 1-year time-limited approach. So these are the pros and cons, which actually I routinely discuss with the patients when we are talking about which therapy to choose in the frontline setting. So that was what is FDA approved. But obviously things are moving forward with other doublets and triplets. So we talked about monotherapy with a BTK inhibitor. We talked about BCL2 plus CD20 antibody, BTK plus CD20 antibody. But then we also have BTK plus BCL2 combinations coming, and then we have triplets, all the three classes of drugs together. So we did a combination study of Ibrutinib plus venetoclax for frontline therapy of CLL. This data we initially reported in a New England Journal paper a couple of years ago now, where we showed that with sequential bone marrow, the number of patients getting MRD negativity continues to improve with time. And then we updated this data at the ASH meeting, where again, for the first 3 months, patients get Ibrutinib alone, and then the venetoclax is added for a total of 2 more years. So when venetoclax is added and when you do serial bone marrow assessments for these patients, at 2-year mark, 66% of the patients were MRD negative, and as a best response, 3 out of 4 patients were MRD negative in the bone marrow with the 10 to the power minus 4 sensitivity. So again, high rates of MRD negativity without the use of an IV therapy, 2 oral drugs kind of together. And then we look at the PFS curves, and by FISH analysis or P53, all are equally doing well and no statistical difference. So that was MD Anderson study. And a large study was done called Captivate study using kind of the same treatment schema, at least for the first 1 year, where they get Ibrutinib for 3 months, followed by one year of the doublet, and then there are some randomizations based on MRD. But I just wanted to, in the interest of time, just want to highlight that in this larger study, 164 patients, again, as was seen in the MD Anderson study, and this multi-center study, again, majority of the patients were MRD negative in the blood or bone marrow. So again, 2 studies independently done, consistent in their finding that you can get high rates of MRD negativity with this approach. And as we kind of showed the MRD, so the PFS, they also showed that the PFS actually looks pretty good for this group of patients, again, with a relatively shorter follow-up of 2.5 months, 2.5 years. But again, these patients are doing well with this doublet regimen. All right, so my second to last slide here. So where is the field moving for the CLL frontline therapy? So I list here, as far as I know, all the frontline randomized phase 3 studies currently ongoing in CLL. And what you can see here, there are several studies which are quite large studies where you have chemotherapy as a control arm, and then a variety of target therapy combinations in the randomized arms. For example, there's Ven-Ibrutinib as a randomized combination here, and there is Acala-Ven versus Acala-Ven-G, so we know versus doublet versus triplet. And then some of the newer trials actually do not have chemotherapy at all. And actually they're just comparing now as a control arm, Ibrutinib-based therapy versus doublets and triplets. So I think these trials are all not reported yet. And I'm hoping that we'll start seeing some of these results in the next 1 to 2 years. And then that may help decide whether which doublet you need or triplet, is triplet better than doublet? So some of these questions, we don't know the answers. Hopefully we'll know in the next few years, because all these randomized studies are occurring right now. So one is my last slide, kind of conclusion, but also at the same time, some unanswered questions to say is that, the first line therapy of CLL, certainly BTK inhibitor is approved. You can use with and without CD20 antibody. We generally use it without. Venetoclax plus obinutuzumab is approved. But then the real question is, do we need CD20 antibody? Can we just do venetoclax plus a BTK inhibitor? Or do we need all 3 drugs together? So a lot of these trials are happening right now. So we'll see what that plans out. If you're using a time-limited therapy, what should be the duration? Should I just go 1 year of therapy, 2 years of therapy, 6 months? MRD-based duration, so that's something unknown at this time. And there's some really exciting work going on in the relapsed CLL field. There was exciting data presented with LOXO-305 in the relapsed refractory CLL. And I think it will be interesting to see how that drug and others move more in the frontline setting eventually in future. So with this, I would like to conclude. Thank you for your time and attention, and happy to take any questions.
Thank you, Jain. Thank you, Dr. Jain, for that wonderful talk. You really made all these trials of CLL so simplified. You simplified all the trials. And we have a few questions here. If you can answer these questions.
Sure.
So, yeah. Okay, the first question, where would you place bendamustine and rituximab in the treatment of upfront CLL in 2021?
So, we don't use bendamustine rituximab here. So the question is, at least if you want to do chemotherapy, the only reason to do chemotherapy would be for this young, fit, mutated IGHV patient, because you believe in this long-term PFS, 10 plus years, half of these patients, 50% of these patients will be alive and in remission. That's the data from MD Anderson. So that's the only reason, but this long-term PFS is only seen with FCR. It has not been shown with BR.
Yeah.
So we don't use BR at all, actually, for our CLL patients. Now, if you want to use it, really, I think I could envision it to use for a mutated IGHV patients, because if you look at the Alliance trial, which I showed you, BR versus Ibrutinib rituximab, if you look at the mutated IGHV patients, the PFS curves are overlapping. So I think for mutated patients, if you want to consider it, I think it's reasonable. But I would say most clinicians and most centers in US have actually moved away from using chemotherapy completely. And if they're using it, they consider really FCR, but not the BR.
Okay. And certain times we do see these 11q deleted patients, which may require an alkylator. Would you use FCR or bendamustine rituximab in younger patients, or use BTK inhibitors or plus or minus CD20 antibodies in these kind of patients?
Again, those are older strategies, I would say. These days, 11q do beautiful with BTK inhibitor, surprisingly. So 11q per se is not a reason to treat someone with the chemotherapy. In fact, most of the 11qs are unmutated IGHV. So I think, so 11q requires an alkylator. Yes, that's a context if you're going to use chemoimmunotherapy. But again, as I said, most of these patients are unmutated patients. You may respond, but these patients tend to relapse later with chemotherapy. So we use BTK inhibitors or venetoclax-based therapy for these patients. That generally is not a treatment, I would say, stratification argument of 11q. Treatment stratification is based on P53, deletion 17p, and unmutated IGHV.
I think the next question, I think you answered this, that in the mutated IGHV, yes, we could still use Ibrutinib-based therapy, or we could go for FCR. So this is something which you answered in your talk. And the next one, what I had, the question was, in the Illuminate trial did not have an Ibrutinib alone arm. But if you look at the Elevate-TN trial, that looked at, it had 3 arms. It had the acalabrutinib plus obinutuzumab. It had the acalabrutinib alone arm. So that's where you could find out, that there was 8% benefit with the addition of obinutuzumab. So what are your thoughts on this? Adding CD20 antibody to acalabrutinib, or the second generation, I'm talking about obinutuzumab, to ibrutinib or acalabrutinib?
Yeah, so you're correct. In the Illuminate study, there was no ibrutinib alone arm. So it's difficult to, so certainly I would not do rituximab to either ibrutinib or acalabrutinib. Now, question of obinutuzumab with ibrutinib, there is no real data, because there's no head-to-head data, I should say. There is some extrapolation from the Illuminate versus the Resonate 2 study, and then maybe there is an advantage of obinutuzumab, but that's like cross-trial comparison. Certainly, I think, so for me, I think we have to see the long-term follow-up of the Elevate-TN study with Acala versus Acala-Obin. If the long-term follow-up shows that Acala-Obin continues to have better PFS, not just the 6% PFS, but it improves with longer follow-up, then that would make a case really that, hey, maybe if you're using Acala, adding obinutuzumab may be helpful to these patients. Again, that argument, can you just extrapolate that argument to ibrutinib? I guess you can, but again, there's no head-to-head data. And as I said, at least in the United States, because both ibrutinib and acalabrutinib are kind of equally priced and available through insurance, and given the safety profile, more and more clinicians are using these days acalabrutinib as opposed to ibrutinib. So I think there's a less, in some sense, discussion about Ibrutinib moving forward um, about that. So yeah, so I think obinutuzumab may be a reasonable approach to consider if you want to add a CD20 antibody.
Yeah, and a quick thought about prophylaxis against pneumocystis and Aspergillus fumigatus. Do you use in your clinical practice or patients on BTK inhibitor?
Yeah, so we don't use it. So yes, there is data out there from other institutions that PJP pneumonia, risk of PJP pneumonia, fungal infection. We actually do not use prophylaxis for either of these, and we really haven't seen significant increased risk of PJP or fungal infections. And the same has been true with some other major CLL kind of centers in the country as well. So we only use acyclovir or valacyclovir for HSV prophylaxis, but we don't use PJP or antifungal prophylaxis with a BTK inhibitor.
Perfect. So this is $1 million question. We keep coming across these kind of situations where, bleeding issues with BTK inhibitors and how to manage. Of course, concomitant warfarin is a total no for this kind of situation. What about dual antiplatelet drugs? What is your thought?
Yes, so those are tough ones because there's limited data. In fact, we are summarizing some of the data from our institution right now about BTK inhibitors and the effect of anticoagulation, and actually more like DOACs and BTK inhibitors. So I actually, if a patient is just on aspirin, I'm okay with the BTK inhibitor. Sorry, but if a patient is on dual antiplatelet, or they are on aspirin and Xarelto, or some kind of a DOAC, then I'm really hesitant to use Ibrutinib for those patients. And given the availability of venetoclax in the United States, I think those are easy patients to consider for venetoclax-based therapy. So if they're on one antiplatelet agent, I'm okay. But if they're on multiple dual, or they are on an antiplatelet and an anticoagulation, then I'm not using BTK inhibitor.
Something which is interesting is the cardioprotective role of Ibrutinib, since it goes in inhibits the collagen. So and it's also reduces platelet aggregation. So what is your thought about avoiding antiplatelet drugs? I know this is a tough question. Maybe your cardio-oncologist may be able to answer this question. But the cardioprotective role of Ibrutinib, and whether you can actually withhold your antiplatelets in patients who have low risk of cardiac disease or this kind of situations.
I'm not really sure. We don't really practice that, I guess, methodology to say that to use antiplatelet effect of Ibrutinib as a cardioprotector. So we have not really used that strategy.
Okay. And last question, probably. So if you have a 76-year-old with hypertension and coronary artery disease on Ibrutinib for CLL, develops new onset atrial fibrillation, how do you manage this kind of situation?
Yeah, so in this situation, temporarily from a practical standpoint, I hold their Ibrutinib for the time being, have them evaluate the cardiologist, see what they want to see in terms of their CHAT score, and if they want to put them on anticoagulation, what they want to do. And again, if for these patients in today's world, when we didn't have venetoclax-based strategy, for these patients, I typically, once their AFib is controlled, maybe a week or 2 weeks down the line, I resume their Ibrutinib, but at a lower dose. Now, if I'm really concerned, if the patient has been on Ibrutinib for some time, maybe 2 or 3 years, they're otherwise doing well, their disease is well controlled, there's no super rush to resume many times Ibrutinib back again. So many of these patients, I hold their Ibrutinib, and actually they continue to do well without any treatment for a prolonged period of time. So as I said, I think because we also have venetoclax available, and what I don't want in patients is that if they're on anticoagulation, then you have Ibrutinib, bleeding risk and whatnot. When you have other opportunities available, for example, venetoclax, sometimes those are the things I'm thinking about for my patients rather than putting them back on Ibrutinib. So maybe not a straight answer to your question to say, but I think certainly I generally tend to reduce the dose or hold Ibrutinib for a prolonged period of time, see if they're doing fine without adding back Ibrutinib.
Perfect. Thank you so much, Dr. Jain. I think the last question is also something which you mentioned previously, that people are clinicians are more tilting towards using acalabrutinib more, and now with zanubrutinib being available in the United States, I think it's more about the second generation BTK inhibitors. Yeah. Now, Dr. Lino, if you have any questions from the audience, from the attendees, you can probably ask those questions.
Yeah, I think there are two questions. I think the first question is to Dr. Rashmi, asked by Bahasa Bagal. TP53 mutation cannot be done in every patient due to cost and non-availability of NGS. So are there any clinical predictors or situation where you suggest strongly doing that? Yeah. Dr. Rashmi is there?
Maybe I can answer.
Yeah.
I'm not sure if she's muted. So, you know, I think to me, I think doing a T50 mutation. Rashmi, you're on? Go ahead.
Yes, I'm on.
So there was a question about TP53 mutation cannot be done on every patient due to cost and non-availability of NGS. What
Yes.
situation would you strongly suggest to do it?
Yes, you're able to hear me, right?
Yes.
Yes, good.
Okay. Yes. So I was just going to say that. So the TP53 mutation, if a patient is being considered for the FCR therapy, I guess that would be a very appropriate scenario where you might want to consider doing TP53. The other alternative is to do TP53 immunohistochemical stain. This is a very good surrogate, a cheap alternate to mutation status. So the way to interpret is if there are more than 10% cells positive, strong positive, it almost always confirms the presence of a mutation. But on the other hand, if the immunohistochemical result is negative, or if less than 10% cells are positive, that scenario, you might want to consider doing a mutation analysis because that way you're not, that would be a bit cost-effective approach to address that.
Yeah, the second question again from Bahasa Bagal as to Dr. Jain. How you approach patients progressing on Ibrutinib? What are the tests and treatments?
Yeah, so this is a patient population we are seeing more and more now because Ibrutinib has been in the market for a few years now, and all patients have been on it, and now they are kind of progressing on Ibrutinib. So these patients, in some sense, some of the tests, as you kind of discussed, we repeat a FISH panel, we repeat a p53 sequencing, just to see if they have acquired any clonal abnormalities which were not present before. Now, at the end of the day, you have to, it's a patient presumably who was either had chemotherapy in the past, then had Ibrutinib, or maybe Ibrutinib was their first therapy. So if they have not received venetoclax, that would be my next step to go to venetoclax rituximab or maybe venetoclax obinutuzumab for these patients. But at the same time, I think you have to start thinking about what's the kind of long-term strategy here. If a patient is 45, 55-year-old, and if they have, let's suppose, del17p53, I'm also start thinking about transplant, allogeneic bone marrow transplant for this patient, because I don't know if venetoclax will tide them over for the next 20, 30 years. Right? I mean, so we need to kind of start thinking long-term. At least in the US, we have CAR T trials available, so that becomes an attractive approach for some of the patients as well. So certainly, I think in short, I think going to venetoclax-based therapy and then thinking about a bone marrow transplant for that patient, depending on the age of the patient, what's going on.
Yeah, I think one of those questions have been already answered by you. If a patient is on Ibrutinib and develops atrial fibrillation and is started on anticoagulant, do we restart with Ibrutinib?
Yeah, so I had mentioned before, I think I have restarted Ibrutinib at a lower dose for these patients. Sometimes if there are more episodes of AFib, then you can hold again, restart at even a lower dose, or then just maybe give a drug holiday for these patients. And many times they do well for a long time. And then if you need to restart again, then you could restart or maybe then consider venetoclax-based therapy rather than subjecting them to Ibrutinib again.
Yeah, one question from Dr. Aparna. When patient is started on Ibrutinib, when should we do reassessment once a patient is started on Ibrutinib?
So that's a very good question. So, reassessment, you're probably talking about response assessment to say maybe, when I start a patient with Ibrutinib, I generally check their blood counts every other week for the first couple of months, and once a month. And then after they have been on therapy for 6+ months, you can do, every 6 weeks or 2 months. And later on in the second year plus, they're getting blood counts every 3 months, and they really do well. If they had bulky lymph nodes to start with, you could do a repeat CT scan 6 months, 1 year down the line, just to see if those are improving, but you can obviously palpate them yourself as well to see if they're improving or not. There's no real role for checking MRD for these patients, in my opinion. I also don't tend not to do bone marrow biopsies on these patients because really they're not going to improve their bone marrow burden too much if they're just on ibrutinib. So the follow-up is actually pretty easy for these patients in terms of many times they're feeling better, you start, check their blood counts, and really there is, as I said, you can repeat a CT scan if you need to, but otherwise it's pretty easy in terms of responses assessment.
Yes, one related question to that, how long will the peripheral blood lymphocytosis persist with ibrutinib therapy?
So generally, so most of the patients, it will persist up to 6 to 9 months and it will resolve by that time. There are around 10% of patients where it may persist beyond 12 months as well. Now, again, I think as Dr. Rashmi had mentioned, for these patients, really, you should not really change any of the practice, what you're doing. Do not give them rituximab or steroids or do anything different. This is expected. Don't worry about it. Tell the patient it's fine. Do not worry about it. Do not change the dose. Keep everything the same and they will do fine. As long as, and most of them, it's really just a reactive lymphocytosis. If they're feeling well, otherwise lymph nodes are decreasing in size. Hemoglobin platelets are improving. So not just need to be monitored, but nothing really needs to be intervened upon.
Yeah, so one question from my side, Dr. Jain, how do you decide between ibrutinib and acalabrutinib in your practice? So any distinction?
So I actually have not used ibrutinib since the acalabrutinib was approved now 1+ year ago. So outside of a clinical trial, I have not used ibrutinib for my patients. I have only prescribed acalabrutinib just because of the data, which I've kind of briefly shared with you. Toxicity data seems better. And I have also treated patients on the previous acalabrutinib phase 1 studies where really they have really minimal side effects as opposed to ibrutinib. So and again, the head-to-head data will be presented hopefully in the next few months at one of the summer meetings with the Elevate RR study, which will further, I think, prove the point which I'm making. So yeah, so I think I'm not prescribing ibrutinib to any more patients since we have availability of acalabrutinib.
So we don't have availability of venetoclax and the other PI3K inhibitors. So any role for sequencing of the BTKIs?
Sequencing of BTKIs, like one BTKI and then you progress and you start another BTKI?
Yes.
So, I mean, unfortunately, ibrutinib, acalabrutinib, and zanubrutinib, all three are what are called covalent inhibitors of BTK, and they have the same resistance mechanism. So if you fail ibrutinib, you're not going to respond to acalabrutinib or zanubrutinib. If you are intolerant to ibrutinib, then certainly you can switch, and that should work. There is a new drug called LOXO 305, which was at ASH meeting and paper came out in Lancet recently. So that drug does work, which is a new BTK inhibitor, does work for patients who have failing ibrutinib, failing acalabrutinib. So obviously that drug is still in clinical trial, it's not approved. We'll have to see what happens with that drug. But so I think sequencing of BTK inhibitor with the current available BTK inhibitors will not work for progression. It will work for intolerance, but not for progression.
Okay, I think that's all. Thank you so much. What about Dr. Vishwanath and Dr. Santosh? Anything to add? Or otherwise, shall we wind up?
For the wonderful talks.
Okay, so I think thank you, Dr. Rashmi and Dr. Nitin, for those excellent talks, touching upon the very relevant and the practical issues in the diagnosis and management of CLL. Thank you, Dr. Vishwanath and Dr. Santosh for setting the stage for the talks. And thank you to all the participants who have asked questions and made it interactive. And finally, thank you, Jason, for providing the web platform and keeping it going without much glitches. Thank you. Thank you so much.